Good morning, everybody. I'm Rhonda Spallmeyer. I am presenting today on progress, not perfection, a discussion about our SDOH data collection and coding. I'm going to take my glasses off so I can read. I need bifocals, but I refuse. So what we're going to talk about today is I feel like I've talked about this for like the past couple of years, and we're finally, I feel like, getting some traction in this, especially with CMS and the requirements for SDOH screens. But I'm really glad everybody has joined us today to define social determinants of health and health-related social needs and what those are and what those mean. We're going to identify components of a successful health-related social needs program. And then we're going to talk about Z codes and their important in SDOH data collection and talk about available resources. I think it's really important when talking about things like this is not just talk about the concepts, but also what do you do with it? And how do you take this from theory and, hey, we've got this regulation, to actionable steps that you can use in your own organizations. First, I want to talk a little bit about where I come from and why I'm here today, and what does Health Information Exchange have to do with any of this. I am a 28-year career nurse in Northeast Kansas, worked in critical access facilities, rural health clinic, that kind of thing. Worked in health IT because nobody wanted to do that and implement their EHR, so I did that. But I landed about 5.5 years ago with Kansas Health Information Network, also known now as KANSA, working with Health Information Exchange as a clinical informatics nurse, really specializing in workflow and making technology useful, or helping clinicians use the technology that's available to them. So a lot of you may know about KHIN, or maybe you don't know that you're part of KHIN when you document in your records and those come magically to our database. But KANSA KHIN is really a mission-driven organization who wants to advance health information sharing for better care management, transformative value-based payment models, because we're all going to that now, and actionable data analytics to improve outcomes. So why do we care about social determinants of health, and why do we care if you're screening for that? Well, we care because that information comes to us, and then it can be shared to other care providers who are also taking care of that patient. So that's why we were very focused on good quality data collection, because if the data is not good, it's not usable. We are a private, nonprofit organization. We are provider-led and provider-governed. So it means physicians all sit on our board. I think we need to add some nurses, but we are provider-led. We are a designated qualified health information network. I always have to bring that up, but doesn't really make a big deal for you guys right now, but it's going to be a big deal in a few years when you can get even more information about your patients from other health information exchanges. We do operate 10 HIEs across 10 states. So for those of you who think we're just in Kansas, we're not. We have 10 state-specific health information exchanges, but we also have a national presence as that QHIN. So we do a lot of different things with a lot of different people. We work really hard on data quality, not just the content, but also the technical structure of that. So we are actually the largest validated clinical data stream. Some of you in this room may have been called by us so we can do your DAV accreditation on your data. Some of you may have no clue what I'm talking about. But basically what it means is that we make sure your data is not only good clinically, but also is interoperable and can be shared among those disparate systems that Dan was talking about earlier. And we also have the highest level of data security. We're ENAC, HITRUST certified, all that good stuff. So I just wanted to talk a little bit about what we are and what we do, because I don't think a lot of folks understand the importance or really understand interoperability and what that means. I know as a nurse, I had no clue until I had to start doing it. Maybe I'll get this to go. Aha. All right, so now we're going to dive into what we're here to talk about today. And that is understanding health-related social needs, social drivers of health, collecting the data, and what do we do with that data? We're not here to solve your issues with, we don't have food insecurity, or we do have food insecurity and I don't know what to do about that. We are here to learn about how to collect this data in a way that can help you meet your CMS requirements, but also help you actually provide better patient care. Social drivers of health, and I really like to clarify what these are. The SDOH screens that we're talking about are referring to the conditions in which people are born, grow, work, live, and age. And that's shaped by a distribution of money, power, resources, and impacted by factors such as institutional bias, discrimination, racism, and more. That sounds incredibly overwhelming, and I don't think any one person in this room is ever going to fix that. But that's where health related social needs come in. That refers to the social and economic needs that an individual experiences that affects their ability to maintain their health and well being. They include things like housing instability, housing quality, food insecurity, employment, all those things that I have listed up there. So if you think about the fact that there's a lot of systemic problems, we're not going to fix. I'm not going to fix it. You're not going to fix it today. But we can address the effects of those systemic problems. And that's what a health related social need is. Somebody may be living in a community where work is scarce. Well, we're not going to drum up jobs for these people. But we can look at how we can address the health related social need that comes from being unemployed. Do they have access to food? Do they have access to utilities, warm water, electricity, things like that? So remember, this is a key takeaway, is that health related social need is a result of the SDOH. An unequal distribution of social drivers of health is the root cause of health related social needs at the individual level. We can't always fix the SDOH, but we can take steps to address the resulting health related social needs. So that is my spiel on what those differences are, because until I understood that, I felt like this is kind of overwhelming. I can't fix the world's problems by doing this screening. What am I supposed to do with this information? Why should you have a health related social needs program? Well, CMS did a long-term pilot program study that looked at what factors affect health outcomes. And I don't know about you, but knowing that almost half of the factors that affect my patients' outcomes are related to their social drivers of health and health related social needs, it's pretty eye-opening. And this was, a CMS pilot. I had no idea they were even doing this until they published this. But just knowing that that's one of the biggest factors, having all of your nurses certified in ACLS, that's pretty important. And that's going to affect a very small number of folks that may need that service. But your health related social needs have a much bigger impact on your population than those other initiatives that you're working through. There are multiple reasons here why it's important, not just from this is the right thing to do for our patients, but other reasons that it's important to have a robust health-related social needs program is an overall reduction in healthcare costs. I don't know about you guys, but when I was the CNO at my small community hospital, our operating margins were like paper thin. So anything we could do to reduce our costs, like unnecessary readmissions, unnecessary, labs, unnecessary things that really, a lot of times we were eating anyway. Making sure that we're addressing those health-related social needs, and if that keeps our patients getting care where it's most appropriate, that helps reduce cost. CMS also has, as a payer, has their hospital commitment to health equity. It's a big thing now, and it's not going away. We also have, in Kansas or in most states, you have your SHIP grants, your Flex, MBQIP, that kind of thing. And then you do have third-party payers. So for example, if y'all aren't aware, Blue Cross Blue Shield of Kansas, as part of their QBRP program, would like for you to be submitting Z codes for your screenings because they need that data as well for their insured folks. So it's not just Medicare. You're going to be seeing a lot more of your third-party payers focusing on this because their bottom line is we want to make money, and if we don't address these health-related social needs, we're not going to make money. We're going to be spending it. Also, and this is really more my fixation is on improved outcomes. You know, what are we doing with our patients? How can we do that better? And there are quality programs in place that are focusing more on health-related social needs. So promoting interoperability, formerly known as meaningful use, and whatever other four-letter words you wanted to call that over the years. Inpatient quality reporting, HQIC, which we just finished our HQIC, statement of work. It was a 4-year program, and that was very successful. There's also HQuIN, and then you have state-specific programs. So you may, your MBQIP. There's always some kind of quality program. KFMC and KHC both focus on these things as well, and they do a great job in helping to support that. We can also, by gathering this data, look at our population health. We anecdotally can say, oh yeah, our patients, we think most of them have heart disease or hypertension, but how many of your patients are unhoused or have food insecurity or don't have enough income to pay their electric bill? And then this is also one of my favorites because as a former CNO, that community needs assessment that you get to do every, was it 3 years now? Where we send out those surveys to the public that they don't send back, or if they do, they're just angry. Those are the people that typically respond. This is a great opportunity for you to use your actual data to help support your community needs assessment reporting. I don't know about you, but if I'm going to do the work, I want to make sure it actually means something. Maybe. Aha. So there is a really, I found this, and none of this is mine. This is all things I've compiled together to help you hopefully not have to go out on the internet and go lost down in a rabbit hole. I've already done that for you because I like the rabbit holes, but not everybody has the time for that. The 5 domains of a health, an HRSN program first, and we're going to talk a little bit about this, but this is kind of and you'll see how I have it in a kind of a circle, because as most of you know, if you're involved in quality, PDSA cycles are never ending. It shouldn't be never ending. Nothing's ever totally fixed. There should always be a reevaluation. So that's why I use the graphic there. But we are starting with strategic planning. And then today we're gonna talk about that a little bit because that's very important. And then the next step is your data collection and validation. And when I say data collection, it makes us all sound like data nerds. We're not. This is nothing more than doing your nursing assessments or asking for race, ethnicity, and language, which does sound a little daunting sometimes. Data analysis, we're not going to talk about that today. I'm sure I'll be doing another presentation on data analysis and how to actually drill down in that eventually. And then quality improvement. And then leadership engagement. So some of these, as well as I do, you're doing some of these all at the same time. And, things get in the way, like pandemics. Hopefully we're done with that. But, but these 5 domains, if you keep this in mind, this, to me, it's very helpful to help guide you in those steps. I love algorithms. I love tasks and to-do lists. So for me, this makes my heart happy. The first thing I want to talk about, because you really can't move into data collection if you don't even know where you're starting from. And I'm guessing that most of the organizations I've worked with started data collection because CMS said they had to, but they didn't really sit down and have a full conversation about what does that mean, what does that look like, and what are we going to do about it. Most of it's probably people sitting at the nurse's station going, why are they having me ask this to this patient? I can't fix this. I don't know what I'm supposed to do with this. We want this to be successful. And even though we know that this is a good thing, sometimes it takes CMS hitting us with the stick to tell us we have to do these things. And then we just react instead of being proactive. So the first thing that I recommend, and even if you start a data collection, you can still take a step backward and do this, is the gap assessment, your health equity gap assessment. You can do a gap assessment on anything, any program, anything you're contemplating. Hey, what do we have? Our goal is this. What do we have in place right now? That gap assessment is part of your strategic planning. It's very important. It's also known as we don't know what we don't know. This is the time to engage all of your internal stakeholders to answer these questions. This is not the time to design or implement solutions, because if you start talking about that, you're not going to get anywhere. You need to start looking at what you have in place, asking questions. And I do have a really good link in the resources, and I'll show you at the very end, where there's a gap assessment related to this. You don't even have to invent that. You don't have to write it up. Click on the link, print it out, and have your meeting. But you'll notice that this isn't just nursing, and this isn't just HIM. This is a meeting of the minds. What I would suggest is you get your social services, your admin, find a physician champion or a nurse practitioner champion, whoever your medical champion would be, because it's really important you have somebody from the medical side supporting this. Your medical and your medical coding and billing, health information management, often those are the same people. Your EHR vendor, and maybe you won't have your EHR vendor. Maybe you have a clinical informaticist, or you have somebody that manages your EHR at your organization that can get these answers for you. Your registration folks, anybody who does registration needs to be involved. Now, in the gap assessment, they don't have to be involved right away. You want leaders from each one of these departments. And then, of course, nursing, because nursing gets to do everything at some point. What I would do is send this gap assessment out. Just say, hey, I've got this. I want you to look at this, and I want you to talk to your staff and answer what you can. And then you have a meeting with those folks after they have completed their portion. And then you put that all in one space and you talk about what you're already doing, what you're not doing, what you thought about doing, you just hadn't done yet, and who's doing it. I don't know how many times we find out, like, you think about registration, for example, and if you're in a small community hospital, you don't have 24/7 registration. So guess who gets to register those patients after hours? Nurses, and we're not good at it. We're not good at, we get them registered just enough to get them in the computer so I can get my orders going. So looking at who is truly completing these tasks is very important. Something that, and there is a very specific question that is really important to the data collection. Does your hospital use a self-reporting methodology to collect demographic data from the patient and or caregiver? And that's your REO, your real data is what I call it, your SOGI, or sexual orientation, gender identity, and your SDOH data, your SDOH or HRS data. That is, the patient gets to respond. Either they are filling it out themselves or you are asking them to tell you what the answers are to these questions. Because what's something we do quite often when we're just flying through stuff, okay, they look white and non-Hispanic. I've done it. I mean, I know these people, I've grown up with them. So I know what they're, they might think they're an Irish Catholic, but they haven't been to Ireland ever in their life. There are some things to do during your gap assessment and the data collection if you're not sure. One is consider running reports out of your EHR to determine if you are using the Z codes, the SDOH codes, or if they're being used. This is a really good place to start, because how much have we learned about quality if it's not measured? We don't know. If we don't know where we started and we're not remeasuring periodically, we're not going to know what our progress is. So most of the times in your HIM modules, you can run reports on diagnosis codes. So you can run, this isn't rocket science. You guys can do that. Maybe you can't, but your HIM should be able to. Consider a manual chart abstraction if you don't have reporting tools available within your EHR to review, notes for documentation. If any of you have been in nursing long enough, you know what I'm talking about with a manual chart abstraction. And even if you have an EHR, doesn't mean there's a report built out for it. So then you go in and you're reading through charts and, so basically let's look at the charts from the last 14 days. Is there any mention of SDOH? It doesn't have to be horribly time consuming. You can also consider partnering with your HIE, or if you have another HIE that you use to do a data review of your SDOH elements. I am right now finalizing a report we ran for 2023 data to see who is sending us Z codes. So I will be reaching out if I don't see any for 2023 to make sure you have something in place if you're one of our customers. So I'm just going to apologize in advance for bugging you. But I think it's important to know, hey, we aren't doing this, or yeah, we are doing it, or somebody's going to say, oh yeah, we do that, and then there's no Z codes. And then consider evaluating your claims data for Z codes. So you can also pull reports out of your claims data as well and run that with your I-10 codes and see how many of these Z codes you have. And we're going to talk about Z codes, don't worry. You guys are going to be so well versed in Z codes by the time we're done with this that you can give the presentation yourself at your hospital. So what is a Z code and why are they important and why do we care? A Z code is nothing more than an ICD-10 code. And they're the ones that are just kind of those one-off weird things that HIM can throw on. I shouldn't say throw on, but they can put on to help clarify situations. They don't necessarily have to have a physician query and a physician approval. They don't necessarily have to go on a problem list, thankfully. And there is a code set within there that addresses your SDOH. So when we talk about using Z codes and why does Blue Cross want those? Why does CMS want to see not just the screenings, but eventually they're going to want to see those Z codes as well, is because of interoperability and data collection deviances that don't let that data be interoperable. So, using a standardized approach to SDOH data is important because we want to meet the needs of the patients by appropriately screening for the right services and referrals. That's common sense. It allows for the streamlined Z code assignment. We're going to talk about that as well. And identifying your population with health-related trends that may be, tackled through non-traditional system-wide relationships, that collaboration that Dan was talking about beyond the hospital and clinic. If you know what's going on with your patients and you have structured data and you can actually pull that out, then you can utilize that for so many things just besides being able to give the patient the services they need. Now we see, oh my gosh, we have a lot of food insecurity in our community. I didn't know about that. What do we do about a food pantry? What are our resources? This also, matches your program scope and staffing based on population needs. Supporting your policy and payment reforms that include appropriate adjustments for SDH. So that drives into your value-based payment models. You know how we're kind of like 1 foot in fee for service and 1 foot in value-based. If any of you know what I'm talking about, it's painful. We have to do really good work, but we may not get paid for it if it's not good enough. So this is going to be very important for you to be able to get this data so that you can help increase your reimbursements when we're moved to a fully value-based payment model, or those ACOs. If you guys know, CMS is going to require all Medicare patients to be part of an ACO. I think by does anybody know 2020 something? I don't know. So you'll be dealing with that. So why Z codes though? Why isn't it just good enough for me to chart patient can't get food? Z codes have been around since 2015, 2016. So they're relatively new if you think about that in the healthcare space, but also not very new. I mean, that's 8-9 years. And now we're just finally talking about them. But they also allow for a structured format and mapping documentation to a problem. So, if a doctor says they have congestive heart failure, there's usually corresponding documentation like an echo with an ejection fraction that's going to tell you and support that, yes, they do have heart failure and that supports that problem. Same concept here. You have a Z code, but you got to have documentation to support that. It supports that automated analysis and reporting for your quality programs. The analysis, and I've touched on this, can be used in your community needs assessment. It allows for implementation without an EHR build out. So how many of you have an EHR and you're like, yes, I really want to do this one thing. And the EHR is like, sure, we could do that. We need $25,000. Yeah, exactly. You don't have to build anything out to apply Z codes because your HIM and your medical coding billing, your EHRs, they actually upload whenever. I think it's twice a year, April and October, where Z code or where I-10 codes are updated, and those will get updated in the system. So there'll be a choice. This one I love. They can be used by coding professionals without physician approval if supporting documentation is present. And this has been since 2018. So your coders, if there is documentation, they can add the Z code. Nurse could add the Z code if you really wanted to, but the coders can absolutely do that. And we'll talk a little more about it. Z codes are also interoperable and shareable across multiple organizations, including your HIE. That's why we're looking at the data that we receive, because if we get it, that means your insurance folks can get it, the claims data, your quality reporting programs can get it. That can be utilized in your ECQMs. It means that it's interoperable. But there are barriers to using Z codes because there's always a barrier somewhere in healthcare. There's lack of structured, consistent data collection and documentation in the patient record. I touched on those manual chart abstractions. How many of you have been in a chart looking for something and there's like 4 different places it could be? Let's not do that. But there's also some caveats to that. Lack of clear organizational goals regarding health equity. That's where your gap assessment comes in, and your leadership needs to understand that this is a big portion of what your organization is going to support. Your lack of workflow development. My title is workflow specialist. You have to have a conducive workflow to do this. There's also a lack of education, training, and understanding by stakeholders. I think I've talked to organizations, I'm like, where are you at on this? And they're like, well, we don't have those problems here. And it's like, yeah, you probably do. You just don't ask the question. Or we've had competing priorities. We haven't, we've got, because we always do. But when you think back to 47% of the outcomes for your patient are from Z codes, that to me is like, that makes this a priority. There's a lack of resources to address more data collection requirements. So there's a lot to be said there, and I'll touch on that. A lack of data collection and code mapping in the EHR. How do you tie the documentation to the code? And I'm going to talk about that too and provide some resources. And there's a lack of confidence and organizational authority to assign the codes. I still have coders who are like, I don't feel comfortable putting this in here. And I'm like, without the doctor, and I'm like, first of all, the doctor does not want to sign off on this. They don't want to be bothered. And your standards and regulatory requirements state that you can if the documentation is present. That's why doing a screening is really important, a structured screening, because there's no question that it was done and then it's appropriate documentation. Lack of processes for resolving Z codes if they are in a problem list. That's why I like to see the coders do it, because it doesn't necessarily always end up in the problem list and have to be managed. How many times have you seen a patient with 60 problems, but there's only like maybe 4 unique ones because somebody just keeps adding the problems instead of editing the current problems? That's a whole other conversation for another day. Lack of solutions to positive screens. If we don't know about it, we don't have to fix it. And I think that's one thing I hear a lot of is, well, if we're screening for it, then aren't we obligated to fix it? Yes and no. You're obligated to do something with that data. You may not be able to fix that patient's issue, but if you came to my hospital with a STEMI, I can't fix your STEMI, but I'm still going to diagnose it and then get you somewhere else where it can be fixed. And then there's always internal and systemic bias. I mean, that's probably one of my biggest pain points is, hey, we need to start collecting sexual orientation and gender identity data, and you get the big eye roll. Or you get, I'm not asking people that. It's not my pig, not my farm. I'm not comfortable. And those are things that have to be addressed. Or, well, we don't have trans people in our community, so I don't need to ask this information. There we go. So using Z codes, this is a this is a graphic from CMS. Like I told you, I didn't invent any of this. I just went out and got it and put it together. CMS think Z codes are so important that they made an entire workflow out of it. And I know this is a lot of data. I like to put my data, everything I'm talking about on the slide so you can take it home and then reflect on it. Um, I may not touch on everything, but these are the things that I want you to take away. So we're talking about in the circled area is really what we're focused on today, which is data collection, documenting the data, and then mapping the data to a Z code. And this is where I go back to I like my steps, I like my algorithms, I like to have a point, 1, 2, 3. The Z codes themselves are they range from the Z55 to Z65, and they're constantly adding more and more and more. I mean, I've seen some that get down to like um, internal relationship issues with step parent, things like that. Um, I mean, they get very detailed. Now, we don't have to get that detailed necessarily. That's where progress, not perfection, is the goal here. Um, so I've got some best practice considerations, and I'll go over that just after I'm done talking about the 3 steps. Um, but SDOH data collection can happen by any person in the healthcare team. It does not have to be a nurse. It does not have to be a social worker. It can be the housekeeper that's in there cleaning their bathroom and they overhear the patient on the phone telling their son they don't know how they're going to afford their medications. And then that housekeeper comes out and goes and says, "Hey, nurse, I just heard XYZ." And so when I talk about this being a hospital wide initiative, I really mean it. Um, So any member can do it. That includes your providers. It can be collected anytime. So from the time they register or even pre-register, clear through their discharge and even their post-discharge call. There is no, okay, we didn't ask it right now, so I guess we can't go back and fix that. Um, so keep in mind that's where that workflow development and education is so darn important. Because I just think about my housekeepers would always come out and be like, "Oh my gosh, I overheard so and so," or they brought the food in. The kitchen staff brought their trays up and delivered them, and the patient said, "Oh, this is so good. I really hate to leave because I won't eat this good at home." So making sure that your staff that has any interactions with those patients understand what they do if they hear something like that, and then you collect it. So that's on to our step 2 of documenting the data. The data just has to be recorded in a chart. It has to be in the patient's chart. It could literally be a progress note. I don't recommend that um, because it doesn't bode well for assigning a Z code unless your coders and billers go through and literally read the entire chart. But documenting it, I mean, we all know documentation, if I got called into court for something I did 10 years ago, I hate to think of what my documentation would look like and if I'd even remember it. But what's important is that you utilize some kind of standardized documentation. I mean, obviously, if you want to add quotes are always my favorite thing. Patient states they can't, they don't have a ride to the pharmacy and the pharmacy won't deliver to their house because their dogs are mean. That would be a very valid one where I live. So there's more, um, you know, regardless of where you document, if you want to add documentation, or maybe the physician put in their clinic note or their office note or their rounds. They come in to see the patient in the morning and they come back out and say, "Hey, I was talking to the patient and they're worried about when they get home if their husband's going to be mad at them for coming to the hospital. And I'm a little worried about that. I'm going to put it in my note." But that's where you should also go back to your screen and then add that, concerned about abuse or not feeling safe. So um, you can, like I said, you can collect very specific detailed data or you don't have to collect very specific detailed data. And I'm going to talk about some examples of what those, what the screening tools can look like. Once it's documented, once you're getting that patient through the system, then you need to map that information. So there's automated ways to do that, and then there's not. And it depends on the organization. You can, some organizations will have, if you have an EHR that's really built out and you do a screen, just like a fall risk assessment, you do that and then you get a score and it spits it out and you're like, yay. And then, and if you're really lucky and you have somebody that can assign, oh, now that initiates our fall prevention care plan. You can get very automated with this, but you don't have to. You can start by, hey, coders, when you're doing the chart, go look at this security or look at this screen. And if it's, if you see any of these, you need to assign the appropriate code. And then they're going to go, what do you mean the appropriate code? I don't even know what these are, but I'm going to help you with that. That's really, and also mapping it. Mapping is kind of a challenge because you guys, I don't know if any of you are coders in here or have done coding, but choosing the appropriate code can be very overwhelming. And if you get it wrong, then it can be very intimidating to think about having to assign that. So some best practice considerations, and I've probably already touched on some of these, is determine who, when, what, and how screenings will occur. And remember, any clinician can perform the SDOH assessment. Patients can self-report. There's options where if you have a fairly robust EHR, you could just, and it doesn't even have to be a robust EHR, you could give the patient a paper screening tool and say, please complete this, because they may feel better doing that without you asking them those questions. And then they give it back to you, you scan it in. But what happens to scanned records in an EHR? Nothing. They go nowhere. So you still got to fill that out with, and then, when you do your standardized screening tool, you're going to say your source was the patient reported screening tool, the patient's own screening tool. Again, making sure that you've educated anybody who may come into contact with the patient and may overhear something that they need to bring that back to nursing or social work so that it can be documented appropriately. It can be documented in the problem list. It can be in the history. It can be in the provider notes, the nurse's notes, the social services notes, structured, or a structured screening tool, which is what I recommend. Now, a lot of us are, and I think about this because I used to have to build out these assessments and whatnot in my previous life, was I don't want to create one more place for nurses to go or social services to go. Social services already does their assessment. Nursing has theirs. Build a screening tool into the workflow. If you're going to go electronic, add the screening tool as part of the workflow your nurses are already in. Please, for the love of all that's holy, do not make them fill out another form. If you can, when you're doing that admission assessment, that's where your SDOH screen needs to be. You may have to get with your EHR to do that. EHRs can be a little special and tricky when it comes to building those things out. But, do what you can to make it less burdensome for your staff, but still effective. And if you have no electronic tool, honestly, this is what quite a few of my Athena organizations are having to do, because Athena didn't, they just don't have that available. They're using their paper screening tool and they're scanning it in, and that's all they have. But that's where that Z code becomes so incredibly important, because that scannable paper isn't going anywhere. Generally, it's not going to be included in a medical record request or release unless it's, printed out specifically. So that's where that Z code becomes incredibly important to be assigned to that. If you're going to do the work, you need to have the diagnosis code with it. And we've talked a little bit about mapping, but the EHR coding modules are configured with updated SDOH Z codes. You want to make sure that that's been done. It should be, but you don't necessarily have to have the Z code in the database for, many EHRs. You can you can hand key in a code if you need to. But this should be, you should be updating, or your organization's EHR should be updating these Z codes every, I think it's April and October, and I mentioned that before. You can utilize a crosswalk of codes for the screening results. So if you're like me and you're like, I just want you to tell me if it's this, then it's, if this part's positive, then what code goes with it. So I do have some crosswalk resources in here as well. And then educate your coding staff, because we've got to do a better job of not being so siloed with our programs. Nursing's like, oh, the code, HIM's telling me I forgot to do this again. And HIM is like, those nurses, it's, you got to work together on this. Where to find the supporting documentation? You need to show your coders where this lives and explain to them that, hey, we're going to put this in the screening tool. It could live elsewhere. Be great if you'd look for it, but show them where that screening tool is and where they can find that information. Educate usage and provide feedback, or evaluate usage and provide feedback. That's where running those, if you do have the ability to run your diagnosis code reports, run it monthly until that's that evaluation part or that study part of the PDSA, whatever quality improvement cycle format you want to use. Are we seeing any of these screens? And then providing feedback. Now, it can very well happen that you don't have one positive screen that month. It really can. I have a hospital out in Western Kansas. They didn't have any positive screens and they were kind of freaking out. And I'm like, that's actually kind of cool. But you may want to consider, are you asking questions correctly? Did you not get a positive screen because of other factors? Things like that. So you really do want to go back and evaluate. And I know that this is hard, but allow extra time to code while this gets started. I know there's some coders out there that are like, I'm under the clock, I'm under the gun. This is where leadership comes in, and leadership has to say, you know what, it might take them a little while to get to the point where this becomes a daily habit or daily workflow for them. There we go. So this is just another step on actually using the Z codes to enhance your quality improvement initiatives. And this is just talking about the different parts of the healthcare team that can utilize it and how they may utilize it. I've talked about this, where those Z codes help you mine that data so much easier than just having those screening tools, because you're probably looking at a manual chart abstraction if you don't use Z codes. Healthcare administrators, and now I've got to look this way because I can't see, the print's too small on my screen. Healthcare administrators, your leadership, your department leadership has to understand what we're doing and why you're doing it. And that's why bringing them in on that gap assessment is so important. Sometimes it's a matter of making it a business case instead of a clinical case, which is, hey, CMS says we have to do this, and if we don't, we could face penalties down the road. Or, hey, if we address these, we might actually reduce our costs tremendously because of this. So we need this information. But they have to provide the resources. So, as with anything in healthcare, right now there is some reimbursements on the ambulatory side that can be. There's some CPT codes that can be used for that in the clinic side, but on the hospital side, you know how it is. I mean, it's all part of the room charge, right? This is also to help leadership get an idea of who outside of the system needs to be collaborated with. I know a lot of the times the programs that I worked on, it was usually me talking to somebody I happened to know at another organization, but you never get that leadership to leadership commitment or that memorandum of understanding if you really want to be structured about it. So that's where your leadership comes in. They should be making those contacts to your community-based organizations. They're the ones that are going to decide if you get to have a community healthcare worker. So it's very important that they be involved in this. They may not, most leadership is like, give me the info and then I will do what I need to do. So they may not dive into this as much as you guys, but they definitely need to have an understanding. And then the healthcare team, really it's using your SDOH screening tool, listening. Most of us have no problem doing a physical head to toe assessment and doing it well. But when it comes to SDOH, Screens, we get a little uncomfortable sometimes. So I do have some resources on how to address that and how to learn to ask the questions and how to ask them in a way that is hopefully not off-putting to your patients. Instead of saying, well, how much do you make a year? There was an assessment I saw and I said, oh, no, 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 no. It needs to be, is your income sufficient to have housing, to have food, to have, that's, no farmer's going to tell you what he makes in a year. I mean, that's between him and the IRS, maybe. So, yeah. So, and then once you start getting into collecting this data, I think what you'll find, and you're looking at it, is you're going to go, oh, we have this need. And that's going to make you go out and actually find resources you didn't even know existed. I mean, just sitting here talking or listening to Dan today, I mean, I'm about an hour and a half from Kansas City, but I'm like, oh my gosh, I didn't even know that existed. That would have been, it doesn't have to live in your community to be helpful. The coding and other professionals, making sure that we're providing that feedback, include them in the process. Don't tell them this is what's going to happen, but this is what we need. How do you suggest we make this happen? And then making sure that there's going to add times and that there may not be an exact Z code for every scenario, but I think they're getting there. It's kind of like the ICD-10 code for like getting hit by an airplane propeller. Yeah, I know. That was bad timing. I shouldn't have used that one. But having a Z code, you just got to find, there's the generic ones, interpersonal relationship issues. Maybe they are having a problem with their, ex-husband's new wife. There may not be a Z code for that, but you can use interpersonal relations. So, screening tool resources, your EHRs probably have decided what they're going to put in there, and you may like them, you may not. These are two that are fairly common. CMS has their own AHC HRSN screening tool. The key is they have to hit, is it 5 domains, 4 domains? Isn't that terrible off the top of my head? I can't remember. But you have to touch on the specific domains. But it doesn't tell you how specific and detailed you get in each domain. So CMS has theirs. There's Prepare. There's so many. And you can make your own. I mean, you don't have to use a canned screening tool because your community may have different cultural implications, or you don't like the way that question was. Hey, what do you make in a year? So there's different options, but there is a website that you can go to that's going to compare. It has a table and it shows you all of the canned screening tools that are available. Like there's some specific for peds. So if there's peds people in here, there's, some that are specific to geriatrics, to psych, and no, your standard run-of-the-mill hospital. But it shows you what they have in them and compares them. So you could use that website to actually pick what you might want to use. And again, you don't have to use a canned one. You can use whatever you want. Most of us are probably going to end up using what our EHR built out, if our EHR built it out. So there's also some guiding principles for social needs screenings. And I think this is it's kind of an art. I mean, I think of it as like taking a history on a patient. Sometimes you have to ask the question 3 different ways before you finally get an answer. Just this resource and the website here, I just did some screenshots, but it just talks about how to give and how to perform one of these SDOH assessments in a culturally sensitive way. That you're not intimidating the patients and making them feel bad. I mean, I know when we added many moons ago the question about, do you feel safe in your home environment, to our ER triage, because it was part of CMS, we had to add that. We were all like, oh my gosh, we have to ask that. So we had, how do we ask this in a way, that's not weird, for lack of a better word. And we got through it. So if you guys can get through it, and then we ask for about, suicide screenings, or do you have, you want to harm yourself? We ask those things all the time. So very similar concept. You just got to start doing it. And there are resources to help your staff. Now, I know this sounds very resource intensive. It doesn't have to be. But you can make it part of your annual training, the getting, your fire and your infection prevention, your online training, you could add that. It could be part of your orientation when you're getting new staff, that kind of thing. I think it's just the importance of understanding this is a system-wide project. Just like infection control is system-wide, so is this. You got to treat it just like that. Z code mapping is just basically, and I've got the websites here, but it's just give you a crosswalk of if you answer this question, yes, this is a corresponding Z code, or this is the category it would fall into. This is really handy for your coders. And there's a lot of coding resources online on the professional coding societies and things like that. HIMSS has a lot of information for them to, that you can use. And this is just kind of a list of the I-10 codes that are the SDOH I-10 codes. And you can see, I think some of these came about last October. So you can see where they added new. There's where you could really get very granular. But my recommendation is don't worry about the granular until you get the basics down. You may, 2 years from now, you might be able to, you guys will be rolling through this and it's going to be old hat. But there's I think there was one about being, what was it? It was an interesting one. Well, there's a lot of interesting ones. So there's material hardship due to limited financial resources, not elsewhere classified. Other problems related to housing and economic circumstances. So the coders can take that off of the screening tool and they can use it from the mapping crosswalk as well. And I just have the website here where they show their updated ones. You can see, like I said, they're updated every April and October. And it's not just Z codes, it's all I-10 codes. I think I've heard rumblings about ICD 11, which oh my God, 10 was so hard to get out. It took us 30 years to get 10 out. Making sure you evaluate the updated codes for inclusion in your EHR, update your crosswalks, and discuss updates with the clinical team to determine if the screens need updated as well. So this is that part of the PDSA, we plan, do, study, act. We need to go back and say, okay, what has changed? And even if you just do it annually, when you do those annual policy reviews that everybody loves so much, this is a great time to do that. You really should have a policy around health equity that is part of your mission at your organization. I'm a policy girly because if you get hit by a train, people still need to know what to do if you're not there. And then we're talking a little bit more about data collection resources. Dan really talked a lot about the real data, and I think this is a great place to start. Our organization last year looked at race, ethnicity, and language data that we were receiving from registration interfaces. We looked at 1,000 messages from every hospital in Kansas that sends us data. And then we quantified it, did they meet a certain percentage of race and or ethnicity and or language? And what we found was so incredibly fascinating. We're not good at it. Basically, we did outreach to any hospital that had less than 80% on any one of those three. And what I found, and we actually provided the information to KHA, de-identified, was that the smaller hospitals did a much better job of getting race and ethnicity and language. But I was like, don't pat yourselves on the back too much. You probably didn't have to ask a lot of questions to get that information. We're not, incredibly diverse in a lot of our smaller towns. A lot of the larger ones, we're not necessarily collecting it as well either, or they're doing really good on race, but not on ethnicity, or really good on ethnicity and not language. So we really want to make sure that folks are collecting that. Now, Dan, I think it was you that mentioned, yeah, the updates. Yeah, we're looking at that now too. Yeah, the OMB standards. So think about when you've registered a patient and you're looking at their race, ethnicity, and the options you have, they're fairly limited, but that's going to change. And so it's going to require us to ask questions. And I sat in on a work group from Civitas where we looked at all of the different potential ethical ethnicity codes or categories, race, language, and that's going to increase a lot. It's, and you got to think about, well, okay, when we're loading this into our EHR and the EHR is building that out, I don't want to have to scroll through 300 ethnicities to get to this. So working with your EHR to make sure that it is set up in a workflow that is conducive to data collection is going to be really important. But if you're not sure, if you're not collecting race, ethnicity, and language data well, it's going to be really hard for you to analyze your outcomes by those things. So Tammy Schmitz is going to talk, or Timmy Bragdon is going to talk later about the project they're doing at Nemaha Valley. And I was so excited about it. They found out they had patients that just anecdotally they're only Spanish language speaking. They collected and they were having problems with the portal because it's not in Spanish language. Well, then they were able to run a report out of their registration to see how many folks in their community spoke Spanish. And they realized that was the second largest language, which makes sense, but second largest language next to English that was being spoken in their community. They had the data to run that report. This is a good way to also look at, like Dan talked about, your outcomes. And okay, are we seeing problems with outcomes related to this particular race, this particular ethnicity? I do want to point out at the bottom here, I just added this yesterday because I just got it, but it's demographic data standards from Civitas Health. That's the organization Dan was talking about. And it's a collaboration of quality improvement organizations and health information exchanges and technical folks in that space. This is going to give you an idea. You can also go to the OMB website and just make sure you're prepared. Get a glass of wine, sit down before you dive into that. But there's also some resources here on just how to collect it. There's a short YouTube video on how to get it and how to ask it. And that can help then also transition you into asking for SOGI data as well, that sexual orientation, gender identity. That one's a little more challenging because when I was in the hospital setting, it was, well, registration doesn't feel comfortable asking this. I get it. I don't think anybody's going to, we can, despite privacy screens, we can all hear what everybody's saying. So that might be something you'd have to think about. It may be the clinical staff needs to ask that. And it's not because we care about who you love or what you're doing. But if you present as male and you still have a cervix, we need to make sure we're doing your PAPs and that your health maintenance is not going to be affected by that. So there are very, very important clinical reasons that information needs to be gathered. It also needs to be gathered so you can provide culturally relevant and accurate care to that patient. And a lot of folks don't feel comfortable necessarily divulging that information, but that's why we have to build that trust with our patients. And something I didn't touch on here yet, but it's going to be really important that you let your community know you're going to ask these things. Community education through social media. Send out a letter to your patient. I know that's a lot, but hey, we send out letters for money all the time. There's no reason you can't send out a letter to, the addresses of your patients and say, hey, we are really concerned about health equity and making sure you have the best outcomes ever. So, 47% of the factors that affect your health are related to SDOH, and we are going to start doing blah, 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 blah. That way, when they come in and you start asking them these invasive questions, you might still have some cranky people, but they're okay. They can just say, I don't want to answer. But it's important to involve your community in that as well. Patient collection of the patient level structured data. This is where you get to ask even more questions. This is where you get that SDOH screen. The links here are for just how to ask the questions and what those screening tools look like. There is, really it's just how to get that information. And then the next column is about qualifying, validating, and sharing collected data. That's why structured's best. I love a great progress note. I mean, that's going to always be my favorite thing to read about a patient because it tells you so much. But most systems, it's not interoperable and it can't go anywhere. So, so it's very important that you have that. So using your Z codes, and I put the resources here. There's a really good article here from the ICD-10 monitor. If you're wanting to really include your billers and coders, everybody needs to feel like they have a part of this and that they are supported. So that's a really good article for those folks. The Gravity Project, which is a really cool, I could spend all day on the website. The Gravity Project is a collaboration of several organizations that are looking at resources for social risk and coding in care settings. So this is where I get into my geek mode of data and interoperability. This is where it goes down. So like your IT people or your people who build reports or are interested, like when I was talking about the real data thing we did with the interfaces. We found out that there were three main root causes. One was it's not being collected at all. Two, it's being collected in a data field that's not interoperable and doesn't go anywhere. And three, the interface isn't configured to send that particular message. So, for example, we had several organizations, all they had to do was reach out to their EHR and say, hey, we need you to turn on the language part for the HL7V2 ADT interface. And you guys are probably like, oh, that is, I don't want to know. I didn't know about it 5.5 years ago either. But it's sometimes it's nothing more than just a technical thing. So, the root cause analysis, and that's where the Gravity Project really gets into how to make this data interoperable. Lots of recommendations there. And how health information professionals can boost SDOH data collection. We need to include those folks. So my last slide here is the resources that I've cited. I also have the links. There's a lot of links embedded into my slides. So if you don't get an electronic copy of this, feel free to email me and I'll just send it to you. But I think Tammy, and they'll have that provided. But if for some reason you don't get it, email me. This is open for everybody. Jennifer? It should be on there. Okay, awesome. And KFMC also they're supporting their health equity resource hub. There's a group of us that have been talking about this. I've put a lot of information in there for data collection as well. So that's a really great, jumping off point. But hopefully this will give you the ability to not have to go searching for a bunch of information. And, I hope that your takeaway from this is that it does not have to be perfect to start. I know for me, it's like, I really wanted to buy this jacket, but do I want to wait until I'm a size 6? I'll probably never get it. So, that's really the approach you have to take to this is we've got to do something. And you want to make sure that whatever you do is effective. So having a plan, having that gap assessment, involving the folks I talked about, and making sure that this is a system-wide program and not just another thing nursing has to deal with. So, any questions? Yeah. Mm-hmm. Awesome. Yeah. Yeah. Don't reinvent the wheel. Mm-hmm. Yeah. Mm-hmm. Yeah. As a nurse, and I'll get to you just a second, Amy, but as a nurse, I didn't know how important what I did in the EHR was until I had to be the person building that out. How important it is that we're documenting in the right place, but that right place is in the clinician's workflow, not over here where they're going to forget about it. Like I remember when CMS decided that we didn't have to do tobacco screening as part of our promoting interoperability, and we had always had it as a required data field. And then Cerner turned that off. And I'm like, but I still want that. And it was like, we still need that data. So it's very important as nurses or other clinicians that are in the room that you're aware of that your documentation doesn't just live in this one little record. It goes a lot of places. And so hopefully it goes a lot of places. And that's why it's important to be accurate and interoperable. Amy? Mm-hmm. Mm-hmm. Yeah. Mm-hmm. Mm-hmm. Well, I believe CMS says it needs to be done on every admission. So if you have somebody that's being readmitted frequently, it's just like you listen to their lung sounds I hope you are, and counting those respirations. You want to make sure that that's being done on every admission. Now, with that being said, there are options for like in the ambulatory space where you can actually bill, but you can only bill every so often. Yeah, six. Yeah. So you could say, well, we're only going to do these every 6 weeks. But I think the idea of you do this assessment and then just like when somebody comes in and they've got medications, you can just quick go over it with them and say, has anything changed? This is what I have. Has anything changed? It doesn't have to be a full on heart to heart counseling session necessarily. It's just, I would say that it should, from a clinical and quality perspective, should be touched on every time. It just doesn't have to be as robust. Well, I mean, the Z codes themselves should be those will go on your claim form. Or they should be if they're not. That I don't know. I think it depends. No, and that's something that blows my mind. It kind of depends. So like Blue Cross and their QBRP for Kansas, they require real data. And that's why we did our initiative. And that's for QBRP. So I think that's one of the biggest challenges as because we all have the different payers. You have CMS, and that's usually at my hospital, that's the big guy. But you have your third party payers. I think if you do if you follow the CMS guidelines, you should be okay. But there are payers that may require more. Now, as far as what the claims are going to look like, that's going to go back to your EHR, your billing, and I'm sure there are ways to configure that. And I apologize, I am not nearly as familiar with the claims portion other than one got rejected and I would have to go back and do something to make it work. So if there's anybody in here that is familiar with claims, feel free to speak up. But I think that eventually, I can't imagine why it wouldn't at some point be required. But absolutely. Claims data there's two types of data that we work with, and there's clinical, which is awesome, but not. And there's claims data, which is your end all be all, but doesn't really tell you a story. And it doesn't really give you a good insight into the actual care of the patient. So what is really awesome is when you can combine them. And we are working on that at KHIN, and other organizations are as well. Mm-hmm. Yes, in the back. There we go. Awesome. Mhm. Mhm. Yeah. Mhm. Mhm. Yeah. Yeah. And I think that's a really good point is that, as a clinician, I don't necessarily have to worry as much about the image of, or that perspective. So, I think that's great. And I think that's what's important is, look at your, and in Kansas, I mean, Blue Cross is our largest third party payer for most everybody. But, what do your payers want? There's United Healthcare. What do your Medicaid payers want? What are those MCOs? Um, and how do they want that delivered? And you're probably, I mean, hopefully they'll all do it the way Blue Cross does, and you don't have to have different ways of submitting that information. You- Um, AI is an interesting thing. um, we are internally talking about AI, and there's not a lot of governance around it right now. So I think that's where um, it can be challenging in that regard. So no, we're not making progress on that. I mean, we're not doing something about that. I think some of your EHRs are going to be, they're starting to implement a few things, but the thing with AI and the way I understand it is that if you're using it in an EHR, every algorithm has to be FDA approved. So it's going to be a while before, quite a few of those are in place. Now, can it be used to combine clinical data with claims? That would be a great thing to do. And like I said, we're talking about it, but it's one of those things where you have to be very careful how that works, and the regulations around that. Yeah, yeah. Gravity Project has guidance on that if you want to look at that. And then somebody else, yeah. I think that is absolutely something that you'll see if you already have a payer doing it, that'll probably trickle down. I can't speak as far as the payers go. I like the Z codes. I mean, my whole role or my whole focus on that is to make sure you have the data you need to mine. I know there are, CPT codes that you can use in the ambulatory setting for the screenings. I'm not sure what that'll look like for the inpatient or the hospital side. Okay. Yes, ma'am. Hmm. Awesome. Yep. Mhm. Does that require the physician to do the screening, or can anybody on the team do it? Mhm. Can nurses do it on behalf of the provider? Because that's in a small clinic, that's what you're gonna have. Okay. Right. Okay. Okay. Yeah. Yeah. And every organization has a different, I mean, every clinic has a little different structure, so that's hard um, to do. But I think that's great. So it sounds like, our MCOs are working on that. Yes. Yeah. And I knew Medicare was working through that.